Thank you, Lior. Thanks for the invitation to be here today. So we're going to switch gears a little bit and talk about a surgical topic. So I would like to start with a case and a question. So if you take a postmenopausal, in this case 74-year-old patient who's had a left breast infiltrating duct carcinoma, and the tumor is 3.5 centimeters in diameter, moderately differentiated, ER95, PR40, and HER2 negative. And we did a segmental mastectomy and a sentinel lymphadenectomy, and we had 2 out of 2 positive sentinel nodes for metastasis. And of course, according to the Z11 criteria, we did not complete the axillary dissection. This patient would be staged as a PT2N1 with a prognostic stage 2A, and we would basically send this patient and get an Oncotype DX score on this patient to make sure that she actually qualified for chemotherapy or not based on the responder trial. But in our multidisciplinary conference, we have had this question on more than one occasion, which is, should we complete an axillary dissection in this patient to assure that she has 4 or more positive lymph nodes or not? And that's a similar question relative to MonarchE. So we all know that the lymph node status is actually important, and on the right-hand side you can see that the number of positive lymph nodes is a prognostic feature associated with survival in breast cancer. But if we look historically at why we operate on the axilla at all, we have over the years thought there were 3 things involved. One was to improve survival, another was to control regional node disease, and the third was to guide systemic therapy decisions. But as we know, over the last couple of decades, we have seen information evolve that sort of refutes the first. And the first is, if you look at the long-term results of a trial that was done many years ago, in the mid-1970s in the U.S., NSABP-B04, there were 1,700 patients who were randomized during that period, and they were randomized to radical mastectomy, total mastectomy plus radiation, or total mastectomy alone. So the total mastectomy alone patients had an untreated axilla. So we can then follow over time what happens in an untreated axilla. And you can see on the right-hand side that there was no systemic therapy in B04. This was purely a surgical trial. But if you look at the patients who had negative nodes, those 3 curves basically are statistically similar. So neither axillary surgery nor axillary radiation improved relapse-free survival rates compared with total mastectomy alone. So there was no difference in disease-free or overall survival in these arms. Interestingly enough, in the patients who had an axillary dissection, in other words, had a radical mastectomy, 40% of them had pathologically positive nodes, but only about half of them actually developed a clinical recurrence over a long period of time. And you can see that the median time to regional node recurrence was about 15 months in this trial. Well, then fast forward to the Z11 trial, which I'm sure all of you recognize, but I want to put the question that I put to you in the context of the Z11 trial. So this was a randomized trial of axillary node dissection in women with clinical T1, T2, clinically node negative breast cancer who had a positive 1 or 2 positive sentinel nodes. And the hypothesis was that sentinel lymphadenectomy alone would achieve a similar local regional control as compared to axillary lymph node dissection in patients with a low burden of axillary disease, in other words, 2 or fewer positive sentinel nodes. Note that these patients were treated with breast-conserving surgery and adjuvant therapy. Mastectomy patients were not permitted in this trial. In the bottom line of the trial, in the regional horizontal line, you can see that the risk of recurrence in those who had an axillary dissection over a long period of time was 0.5%, and in those who had a sentinel lymphadenectomy alone, it was only 1.5%, and those two were statistically similar. So the hypothesis was confirmed that sentinel lymphadenectomy alone provided really good local regional control comparable to that of axillary lymph node dissection in patients with T1, T2, clinically node negative, with sentinel node metastasis that were treated by breast-conserving surgery, radiation, and systemic therapy. So this slide demonstrates that similar results were achieved in the AMAROS trial, which was a similar study done in Europe, in which patients were randomized either to axillary radiation or axillary surgery, and the results were essentially the same. Note that in both of these trials, the lymph nodes were assessed by clinical examination. I basically quippingly say to my residents that clinical examination is lousy, and indeed you'll see that we have evolved to where current therapy or current diagnostic procedures include ultrasound in many institutions, but here in both of these trials, clinical examination of the axilla was the entry criteria. And I'll tell you that the number of patients, or the percentage of patients with non-sentinel nodes positive in both of those trials was about the same, about 27% in ACOSOC Z11 and about 33% in AMAROS had pathologically positive lymph nodes in the axillary dissection arm, and yet the development of clinical metastasis occurred in a very small percentage of patients. So based on these data, which demonstrated no survival or regional control benefit to axillary lymph node dissection over sentinel lymphadenectomy, most early-stage hormone receptor positive HER2 negative cancers have a sentinel lymphadenectomy alone when there's one or two positive lymph nodes. Now, if we go to the RxPONDER trial, which Kristen so elegantly told you about, where patients were entered into this trial with 1 to 3 positive lymph nodes, you can start to see where the conundrum occurs between the surgical mentality of stopping with 1 or 2 lymph nodes and the question about how many lymph nodes in the axilla are really positive. Here was in RxPONDER, 1 to 3 positive lymph nodes were the inclusion criteria. And as Christy has so nicely demonstrated, the postmenopausal disease-free survival rate was essentially the same in postmenopausal women, but there was an advantage in premenopausal women to the addition of chemotherapy over endocrine therapy. And you'll note that in this trial, 39% of the patients actually had a sentinel lymphadenectomy alone. Not all of them got an axillary dissection. And so patients included in this trial actually fit the concept that we're going back to about the patient I presented to you. And you can see that in the forest plots, it did not matter whether they had a sentinel lymphadenectomy or an axillary dissection. Axillary dissection did not confer an additional benefit over sentinel lymphadenectomy in this trial. Now, if we go to MonarchE, MonarchE is a similar problem and concept for us. This was a trial that was done in high-risk patients who had 1 to 4 positive lymph nodes. And the criteria for high risk were basically T3, grade 3, or Ki-67 greater than 20%. And they were randomized to either abemaciclib plus endocrine versus endocrine therapy alone. Now, these are high-risk patients, so most of them had either neoadjuvant therapy or systemic therapy. And in this trial, adjuvant abemaciclib plus endocrine therapy significantly improved invasive disease-free survival in this subset of patients. So ER positive, HER2 negative, high-risk, node positive patients. So it's pretty clear what happens in high-risk patients, but what happens if the patient has 1 to 3 positive nodes, but they don't have other high-risk features? should they have an axillary node dissection to determine whether they have 4 or more positive nodes. So you recall the patient that I presented to you had a T2 tumor, not considered high risk according to MonarchE. Had a moderate grade tumor, not high risk. So the question basically evolves to, what do you do with this patient who does not fit the high risk features? Should we consider doing an axillary dissection to decide whether the patient conforms to the criteria? Well, if you look back at MonarchE, the type of axillary dissection was not defined in the trial. And indeed, the clinical node status wasn't defined in about a third of the patients who had neoadjuvant chemotherapy. And if you look at the subgroup analyses, they were just not powered to address whether there was an association between the number of positive nodes and the effect of abemaciclib plus endocrine therapy. So you could, in theory, consider axillary lymph node dissection in patients with 1 to 3 positive lymph nodes who don't have high-risk criteria. Well, I'd like to frame the question a little bit differently and ask the question, what is the likelihood that the patient would have 4 or more positive nodes if we went back and completed an axillary dissection? And so if you try to answer that, you have to sort of look around carefully to find the data to answer it. If you go back to the Z11 trial, and I would re-emphasize that these lymph nodes were assessed by clinical examination only, not ultrasound. In the axillary dissection arm, 13.7% of the patients had 4 or more positive lymph nodes, which is interesting. That's a point where you could have an argument about whether to take the patient back or not. But there are other data sets that we can actually go to look at to try to answer the question. And this might be the best that's out there at the moment. This is a long-term study from Memorial Hospital in New York of 2,600 patients. And the question was, how many of those patients had 4 or more lymph nodes or had T and 2 and 3 disease? So the answer was, overall, 3% of that population had 4 or more positive nodes. But if you start to look at the subsets, these are postmenopausal women. So if they're between postmenopausal, however you define that, let's say 50 and 65, 4% of those patients had 4 or more positive nodes. But if you look at tumors that were T2 or greater, it increases to 13%. And if you add multifocality or multicentricity, it's 8%. If you look at all 3 of those clinical pathological features and put them together, 26% of those patients had 4 or more positive lymph nodes. So you can use preoperative variables such as age, tumor size, and multifocality, multicentricity to identify, potentially, patients who are at higher risk of having 4 or more positive lymph nodes. Another data set that's available to look at is from Dana-Farber. This is a series of patients between 2016 and 2020. They had 770 patients there. 197 of them had a sentinel node plus or minus an axillary dissection, and only 1.5% of those patients had 4 or more positive nodes of the group that had an axillary dissection. Cantor and colleagues, which is Beth Mittendorf and Terry King, also from Dana-Farber, looked at the National Cancer Database in the United States and determined that only 1.6% of 13,499 patients who had an axillary dissection actually had 4 or more positive lymph nodes. So contrary to the Z11 data, we're seeing here that the risk of having 4 or more positive lymph nodes is really quite low. So let's go more to a more contemporary study where the use of axillary ultrasound is used pre-treatment to evaluate the axilla. This is currently what we've been doing for the last 10 or 15 years, and we use it significantly for our targeted axillary surgery. But if you look at retrospective studies that have actually used ultrasound, the rates of having 4 or more positive lymph nodes If the ultrasound is negative pre-treatment, the risk of having 4 or more positive nodes is less than 3%. On the other hand, if the ultrasound demonstrates suspicious lymphadenopathy prior to treatment, the risk of having 4 or more positive nodes is anywhere between 8 and 31%. So it starts to become appreciable, and you can see how the use of ultrasound can stratify the risk of having 4 or more positive lymph nodes. There are now 3 trials that have looked at the use of axillary ultrasound to evaluate the axilla, and you can see them here, the sound, ensema, and boot trial. And the ensema trial has 4,100 patients assigned to the sentinel lymphadenectomy arm, and you can see here that only 0.3% of those patients had 4 or more positive lymph nodes. So we appreciate that RxPONDER and MonarchE are systematic therapy trials, but they're interpreted in the context of axillary node burden, which was determined by a surgical trial. So we have to merge the 2 concepts. Nevertheless, the overall likelihood of having 4 or more positive nodes in a postmenopausal ER-positive HER2-negative patient with a clinically negative axilla is low. It's 3% or less. One could use preoperative variables such as age, tumor size, and multifocality or multicentricity to identify patients at higher risk of having 4 or more positive lymph nodes. And so I would conclude by saying that for patients who are ER-positive, HER2-negative with a clinically negative axilla and 1 to 3 positive sentinel nodes, you could consider an axillary dissection in individual circumstances. But the routine use of an axillary dissection is probably not necessary to satisfy the criteria for RxPONDER or MonarchE to determine the recommendations for systemic therapy. Thank you.
What are you recommending for patients that receive neoadjuvant chemotherapy with a positive sentinel lymph node?
Surgically?
Surgically.
So we put a number of patients in Z1071. We still work through that process. So we do a targeted axillary dissection. So the patient starts out with a pathologically positive lymph node, gets neoadjuvant therapy. If the nodes are clinically negative at the end of the neoadjuvant, then we do a targeted axillary dissection. We use wire localization. Some of my colleagues use the Savvy, but I still use wires. So we use a wire-localized sentinel lymph node, and we also put patients in the trials that help guide us whether the nodes are positive or negative. So we would do a sentinel node biopsy. If the lymph nodes were negative, those patients would be enrolled in B51, and we would do no further axillary surgery. B51 is a trial of radiation, no radiation in the node negative group. On the other hand, if the sentinel lymph node is positive, we were putting those patients into A11202, which was basically axillary radiation versus an axillary dissection. That trial is also completed accrual. So our targeted axillary dissection helped us reduce the number of axillary dissections that we were doing and still put those patients in randomized trials.
A question and note. In 11 years, I will not be here. That's definite. And I'm sorry that the study you mentioned was not performed before to see if the addition of chemotherapy to castration by hormonal therapy is of any benefit, because I don't believe you will find a benefit. The other question is, being a son of an accountant, what is the difference between 25 and 26? If I have a debit in the bank of 25 shekel, they don't call me. They don't call me even if it's 26. You include 26 to 100 in one group. Isn't it stupid?
Thank you for that question. I think it was all based on the 31 to 100, and it was based on the National Cancer Institute not wanting to randomize in that group because of the original trials of B20 and 8814. But we have a lot to learn. We have a presentation this morning on 26 to 30 and what has been found within your database on those patients, but they are not randomized. And we will have those patients randomized now from the West German study group, the ADAPT cycle trial, to endocrine therapy with a CDK4/6 inhibitor versus chemotherapy. But you're right. The analyses of 26 to 100 are just one group, and clearly having a recurrence score of 26 versus 50 is a very different prognostic group and a very different group in terms of response to chemotherapy. My only defense is these aren't our trials. These are nationally supported trials run by cooperative groups, and that's how these analyses have been done. We're waiting for the responder data to be sent to us. We're going to completely reanalyze the responder, and we're going to reanalyze it for distant recurrence rather than IDFS to get us a better sense of if you have a recurrence score of 0 or a recurrence score of 15 or a recurrence score of 25, what is the difference there?
I'm always surprised that neither Dr. Yoshushan or Professor Solomon don't recall their study, their own study of Clalit, even small numbers. There was no difference, or Solomon, correct me, of 1% between 26, 27, 28, 29, and 30. The groups were small, but it seems to be that we are gaining very, very, very few years and torturing too many patients.